We share some of the results of the ACCESS trial. Specifically today, we reported the outcomes of patients receiving highly mismatched grafts, that is, transplants from a donor match at a less than 7 out of 8 level, and we compare that to patients receiving a single antigen mismatched graft, 7 out of 8. The preliminary results of the ACCESS trial were presented last year, and the focus of the study today was to evaluate the impact of levels of mismatch in transplant outcomes. And what we found was that irrespective, outcomes were similar between patients receiving a single antigen mismatch and a highly mismatched graft. And this has very important implications for access and equity. Patients who are ethnically and racially diverse are not only misrepresented in the registry, but they also have a much lower likelihood of identifying a fully matched donor. So oftentimes for these patients, the only options to proceed with transplant is to receive a highly mismatched graft. The problem is that when we use traditional GvHD prophylaxis, with each degree of mismatch, we pay a penalty, and there is increase in mortality when traditional prophylaxis is used. So the idea was, the question that we wanted to understand was, if with the PTCy platform, outcomes between highly mismatched graft recipients were comparable to that of patients receiving a single antigen mismatch. And what we found was that survival and other important secondary endpoints were comparable. We also looked at registry data from today showing that availability for donors, irrespective of race and ethnicity, increases significantly when we are permissive to higher degrees of mismatch. And that means that this graft source has the potential to improve access and equity, particularly for patients who are ethnically diverse, but also by counting with a much larger donor pool, we can optimize non-HLA donor factors that are known to affect transplant outcomes. So we can find a donor for every patient, but we can also find a better donor for that individual patient that you're seeing at the time. We have additional studies building up on this platform. We're trying to evaluate combination of cyclophosphamide, changing or reducing the dose of cyclophosphamide to minimize some of the toxicity, and see if we can continue to provide safe transplantation with good protection against rejection and GvHD, while also minimizing toxicity.